I'm Dave Tweed, and welcome to the fourth airing of Endoscopy Talks. Um, we need to be thankful for Colorado State University's new Translational Medicine Institute and Karl Storr's Veterinary Endoscopy for supporting these endoscopy talks. And last but not least, I would like to thank all the speakers for presenting in the Endoscopy Talks series. Each speaker has volunteered their time to present in these talks, and we're very grateful for them for doing this. And with that, I'd like to introduce our speaker today, a good friend and colleague, Dr. Lynell Johnson. She's a professor in internal medicine at the University of California at Davis. She's a world authority on small animal respiratory disease. She's done extensive research in respiratory disease, has published in the areas of respiratory disease. She is the section editor for Current Veterinary Therapy Respiratory Section and is the author of the text Canine and Feline Respiratory Medicine. Her talk will cover endoscopic handling and maneuvering through the airways with focus on the anatomy and performing BAL. So with that, I'd like to turn this over to Lynell and she can go forward. So Lynell, it's all yours.
Thank you very much, Dave, and thank you to Colorado State and Karl Storrs for sponsoring this talk, and to Dave and Christopher Shamness for inviting me to talk about what is one of my favorite topics. Bronchoscopy is one of the most fun things that you can do on Earth, and for those of you that are already doing GI or urinary endoscopy, I think if you consider doing bronchoscopy as well, you'll be very happy with this adjunct to your practice. So this is an outline of the talk that we'll go through, some equipment issues, how we do bronchoscopy itself, including the anesthetic protocols you might consider, and then we'll go through the various interventions that we perform when we do bronchoscopy. This is an introduction to the endoscopy suite at UC Davis. We have a relatively small room, but we've packed it full of equipment. We have 3 different tables, 1 dry and 2 wet, so that we can have multiple procedures going on at one time. One of the important things I'll point out in this slide is the endoscopy storage system. For those of you that have a lot of endoscopes or you use your endoscopes frequently, you know that proper handling and storage is critical for avoiding any damage to the endoscopes and also maintaining them in as clean a condition as possible. So our endoscopes are cleaned using a glutaraldehyde-based product, and then they're air dried in our cleaning room and then hung up for storage. We have a large endoscope that we use for after hours endoscopy, and then most of our standard bronchoscopes are in this closet. One of the important things I'll point out is you want to keep all of your endoscopes away from any of the hinges because they can get trapped in there and broken. Our smaller endoscopes, so those under 3 millimeter outer diameter, are generally stored in their containers above the endoscopy storage. This is our typical endoscopy table where we do rhinoscopies, bronchoscopies, gastroduodenoscopies, anything that could lead to leakage. We have a suction canister beneath. We have our endoscopy capture imagery on the left, and one of the important things that we have right next to all of our endoscopy tables is a crash cart for any emergencies that might occur, and these are checked daily and weekly to make sure that everything's up to date. You can see that we have a number of different sized endotracheal tubes, and we use 4 shortened endotracheal tubes that have been cleaned for our bronchoscopy. So we take multiple different sizes of our endotracheal tubes, and we cut them to a shorter length so that they don't interfere with the endoscope as we get down towards the carina. So standard size 8 endotracheal tube has been cut down to about 7 to 8 inches, and then the 14 is closer to 12. And we want to be able to embed the endotracheal tube as deep into the larynx as possible so that we have optimal working length of the scope. We have a rule at our practice where we use endotracheal tube adapters for bronchoscopy in any dog that will accept a size 7 endotracheal tube or larger. And in those instances, we will use a 4.9 millimeter or larger outer diameter bronchoscope. We do not put our smaller bronchoscopes through an endotracheal tube adapter because of fears about damaging the scope. And we'll talk about that again when we get to the discussion of anesthesia. We have multiple portable towers in our practice because it's pretty common that we move from our endoscopy suite to the emergency room to minor surgery, which is right next to our anesthetic and induction area. And we also have to go to fluoroscopy or to cardiac catheterization or into a specialized OR for performing endoscopy. So we have multiple different towers, both Olympus towers and Storrs towers that we can use with our different endoscopes. Now, I will readily admit that I am spoiled for choice at UC Davis. We have 6 or 7 endoscopes that are smaller than 4.9 millimeter outer diameter that I can use for bronchoscopy. And that speaks to the respiratory caseload that we have here at Davis. Rhinoscopy is the most common procedure we do, followed by bronchoscopy, followed by gastroduodenoscopy, GI procedures, and then cystoscopy, which is a very rapidly expanding area for us. Couple of important things about endoscopes that you might consider for use with bronchoscopy. The outer diameter is critical to assess because the smaller the animal, the smaller the endoscope that we would want to use. In cats and in small dogs, we usually use the 3.7, the 2.7, or the 3.8 millimeter scope. Notice that all of these endoscopes have a 1.2 millimeter channel, which means that they will accept instruments that are 1 millimeter in outer diameter. Our larger scopes are primarily the Olympus scopes. They have 2 millimeter channels and will accept a 1.8 millimeter instrument. The one thing that's important as you start expanding your repertoire of endoscopes, you want to make sure that you have the right equipment, the brushes, the biopsy instruments, the grabbers that will go through those scopes. The other thing to consider when you look at purchasing endoscopes for use in respiratory endoscopy is what type of animal do you think you'll be scoping? If you're looking primarily at small dogs and cats, then you'll probably want to use one of these smaller endoscopes. So the Flex XC from Storrs or the Olympus BIF 3C160 are going to be appropriate units to use. On the other hand, if you have a lot of large dogs in your practice, if you're extracting a lot of foreign bodies, the Karl Storrs extended length bronchoscope is going to be a good option for you, or one of the Olympus scopes. The image at the bottom of this slide shows the openings of the scopes and the outer diameters. A couple of really important things. Some of these are video scopes, some of them are still fiber scopes. So we have the video chip on the end as well as a light source, and then the biopsy channel is crucial because it's the biopsy channel that you'll use for passing instruments and also for doing bronchoalveolar lavage. If you don't have a channel, then you're going to have to be relying on a blind BAL to obtain a sample. couple of other important things about the bronchoscopes is their angle of deflection and how the tip works in the endoscope. Now, one of the things that we know is when the scope is flexed in an upward direction, it has the maximal angle of reflection. So in most bronchoscopes, it'll be 180 degrees. If you're using the Flex XC, that will flex 270 degrees, which is a great option for trying to maneuver into the cranial lobar bronchi. One of the things to watch if you are interested in the Flex XC is that it actually has two different handle types. One I call the bronchoscope handle, which is where you push the lever down and the tip goes up. The cystoscope's channel, or the cystoscope handle, when you push the lever down, the tip actually goes down. So make sure you talk to your store's representative before you buy one of those scopes so you make sure you get the type that you want. We've had both of them in our hospital, and now we rely primarily on the bronchoscopic handle for use. Another important thing that you're going to use periodically is the flexion and also wrist rotation to maneuver the scope to where you want to go. So you can see in this image that the endoscopist is holding the scope in the left hand. And endoscopy is always done with the scope in the left hand, and the umbilical cord will go off of the wrist side of the hand so that if you happen to drop the scope, the wrist will grab a hold of that umbilical cord and the scope won't drop to the ground. So the thumb is going to maneuver the up-down portion of the scope handle, and then we use the left-right maneuvering to move the scope in a different manner. Now, the important thing about tip deflection is that we always have to know where the tip of the endoscope is within the airways so that we can make it go where we want to go. So the lever goes down and the tip goes up. Point your hand towards the right, and that's going to move the tip towards the left side of the screen and into the left side of the bronchus. And this will become more evident as we look at some videos of animals doing bronchoscopy. Now, we also have several scopes that have four-way flexion. I call these the GI type endoscopes. This is the handle type that we have in our large bronchoscope, the GIF XP180N that we use for foreign body retrieval in large animals. And if you do GI endoscopy a lot, you know that the big wheel moves the scope tip up and down, and then the smaller wheel will move the scope tip left and right. And again, this is really helpful for making sure that you can pass the instrument exactly where you want to go in the airways. Now, if you have smaller hands, it can be difficult to maneuver the GI scope with just one hand. Sometimes what I'll do is I will grab a hold of the large wheel with my thumb and my middle finger, hold that in place, and then I'll use my other hand to manipulate the smaller wheel so that I can move the scope and move the tip in a left-right direction. Now, we've just gotten this super nifty new scope from Olympus. This is a standard size bronchoscope, 4.9 millimeter outer diameter, and it has a rotating bar at the shaft of the scope that will move the scope in a left-right orientation. So this is a pretty nice function of this Olympus scope. I have to confess I don't use it very often because I tend to use my wrist maneuvers to rotate the scope in a left-right direction more commonly. But it can be helpful in some situations when we're having difficulty maneuvering into a tight spot. Now, I mentioned to you before that we always want to hold the endoscope in the left hand and the umbilical cord will go off around the crook of your thumb, so that if you happen to lose grip on the scope handle, you will catch it before it falls. In the image on the right, our lovely resident is showing how we're going to support the endoscope as we pass it through the endobronchial adapter, through the endotracheal tube, and down into the animal. One of the other things that this picture illustrates is that we always want to make sure we watch the bend in our endoscope so that we don't cause stress on the break point of the scope. There's a couple of areas of any endoscope where it can cause damage if you bend it too much. One is at the junction between the handle and the shaft of the bronchoscope, and the other is in the specialized rubber tip. So those are really important areas that we want to avoid bending. So that's what I had to talk to you about the equipment. Dave, if there are any particular questions about equipment that I can answer, we can have.
Yeah, actually, we don't have any questions yet, so you're probably answering everything, but I would encourage people, if you do have a question, to just go to the Q&A and type in your question.
Great. I think that the questions that arise with equipment can be answered well by your representative that you talk to. So we're going to talk more deeply about bronchoscopy, and one of the important things to consider is when should you do bronchoscopy, and I guess I would answer when should you not do bronchoscopy, because I have done far more bronchoscopies than tracheal washes since I've been here at Davis, and it is, as I say, the most common procedure that we do. I think it's a great technique to use for chronic cough because it allows us to visualize the airways, it allows us to target a specific area for lavage, and it certainly is a useful tool for investigating hemoptysis because we can follow a blood trail down to the specific region. Now, a lot of the cases that I see have already had a tracheal wash, so I'm not saying that a tracheal wash is not a good technique to use. In fact, I encourage all my referring veterinarians to do these before they send them up to me, but it certainly is a very common technique that we use on a referral basis. And as I say, I think it is a tool that you can use in practice. If you're already doing GI endoscopy, you know how to handle a scope, you have some of the more expensive supplements that go along with endoscopy, it's a really useful tool to add to your diagnostic armamentarium. A couple of things to consider about bronchoscopy. It is a procedure that requires general anesthesia. And so if you're thinking about the cases in which you do bronchoscopy, it's an animal that already suffers from some respiratory embarrassment. And so there are some considerations that we have to make before we choose to do bronchoscopy. Is it safe to do the procedure in that animal? Can I do pulse oximetry or a blood gas analysis before I do bronchoscopy to make sure that I have good baseline values? If you feel comfortable anesthetizing an animal, then you should feel comfortable doing bronchoscopy in that patient. One of the other concerns is that if it's a very small animal and we can't intubate that patient, do we feel comfortable with using mask oxygen or supplementing oxygen without the ability to pass an endotracheal tube? So I think choosing the patient in which you're going to do bronchoscopy is a really important consideration. I would also say that one of the most important things about doing bronchoscopy is that we do it rapidly and efficiently. So it does require a good relationship with anesthesia, good communication with that whole service or the person doing the anesthesia, as well as your own technician. So we need an anesthesia, the technical staff, and the bronchoscopist working in coordination so that the procedure runs smoothly. From the endoscopist side of things, I would say the most important thing is that I know the anatomy. I know how I'm going to perform the procedure. I know what's most important. Is it to retrieve a foreign body? Is it to obtain a BAL? And I communicate that with my anesthetist. I would say that the most important thing regarding anesthesia is that we have a balanced protocol for that animal that avoids excessive excitation and that provides a very smooth induction. For very anxious or very fractious animals, it's not uncommon for us to use dexmedetomidine, although I don't like that pre-medicant for doing laryngeal exams. I prefer at all times if we can use butorphanol. It's also a nice cough suppressant for the animal. And I try to avoid the heavy narcotic agents like oxymorphone or morphine because they tend to make the animal pant. And as you all know, it can also make the animal vomit before the procedure, which is not good when you're trying to evaluate a respiratory patient. It is critical that all animals are pre-oxygenated for 5 minutes before we induce anesthesia, because that will hold your PaO2 at a higher level as we prepare the animal for the delivery of oxygen. So it gives you some time to allow the drugs to have an effect while we do our induction of that patient. Most of our patients are induced with propofol and midazolam. Sometimes we'll use alfaxalone, although I don't like that as much as propofol. I don't find it's as predictable as propofol. And occasionally we'll use ketamine and Valium. But usually it's going to be propofol and midazolam to effect. Notice I didn't really give you any drug dosages on here because it's important to tailor the drug dosage to the animal and use a combination that's going to be the most smooth for that particular patient. Now, I do think it's critical when we do a respiratory procedure, whether it's rhinoscopy, bronchoscopy, or a tracheal wash, that we do a good laryngeal exam on induction. And this video from Brendan McKiernan shows a stimulated laryngeal exam with the administration of doxapram. You may have noted at the beginning of this procedure, we see that there's very little motion of the corniculate processes of the arytenoid. We also see accumulation of secretions ventrally. Now we give doxapram and there's exaggerated motion, but it's on inspiration, inspiration, inspiration. Instead of abducting, we actually see that the larynx is moving inward. So that is paradoxic laryngeal motion consistent with laryngeal paralysis. Now, we did a prospective study looking at laryngeal function in dogs with chronic cough. So not dogs with stridor, not dogs with inspiratory respiratory effort, just chronic cough. And we found evidence of laryngeal dysfunction in 19%. So paresis or paralysis were found when we looked at 120 dogs. And I think that's a really important finding because low-grade aspiration injury plays a huge role in cough. And identifying this at the time that we do bronchoscopy is very, very important. Now, I mentioned earlier that if we can fit a size 7 endotracheal tube into an animal, then we can intubate that patient and maintain anesthesia with a gas anesthetic protocol. And we would also use this endobronchial adapter that the scope can pass through. So we make sure that there's no resistance to passage of the scope as it goes through here. So a light non-bacteriostatic lubricant is applied to the end of the scope, and then the anesthetic circuit is attached to the top. And as I mentioned before, we use a shortened endotracheal tube. There have been some occasions when we've used laryngeal mask anesthesia, as shown on the right-hand side of this slide. I haven't found this to be tremendously useful. However, it does allow you to look at the larynx as you pass a flexible scope, but the angle at which this laryngeal mask will connect with the endobronchial tube adapter makes it a bit awkward for use. So it's helpful maybe in a brachycephalic to keep the scope clean as you go down into the airways, but we don't use those very commonly. In our small dogs and cats, we're going to use a propofol infusion and jet ventilation to provide oxygenation throughout the procedure. So in this particular cat, you can see that we have a catheter attached to the jet ventilation unit. And this is just a standard 5-inch intravenous catheter that we pass into the trachea and attach it to the jet ventilator. If you don't have a jet ventilator, you can attach a catheter to the oxygen delivery unit of your endoscope, of your anesthetic circuit. You just have to watch that you don't have too high of a flow rate, which might cause some airway injury. You can also pass oxygen through your bronchoscopic channel. But again, you have to avoid excessive oxygen flows that might cause airway injury, and you'd have to disconnect that oxygen when you go into an airway fully so that you don't cause airway injury. Remember that the scope and any instruments you pass can cause airway injury. You can go through the airway, or you can cause barotrauma with excessive oxygen administration. We do all of our bronchoscopies in sternal recumbency. I have heard of some people doing them in lateral recumbency because that helps with the angle of the scope in entering into the airways. But I was taught to do them sternally, so that's what I always do. We have the chin elevated and propped up on a small towel or a gauze roll. And we use 2 large mouth gags when we do bronchoscopy, because what we want to extend the jaw adequately so the animal doesn't yawn, try to wake up during anesthesia. And if one of those mouth gags comes out, then we have the other mouth gag secure so that the animal doesn't bite down on the scope. It's really important when you're doing bronchoscopy, if the animal starts to wake up from anesthesia, the first thing you do is pull the scope out of the airway, and then I will release the mouth gags as well. Now, probably most of you are aware that in cats, we have to use mouth gags very cautiously because the blood supply to the retina goes around the angle of the jaw, and excessive expansion of the jaw can cause attenuation of retinal blood flow and blindness. The other thing that we do in cats is we always give terbutaline right around the time of the procedure, either right before the lavage or before and after the lavage, and that's to combat any bronchoconstriction that might occur from the injection and aspiration of BAL fluid. Now, I mentioned earlier that one of the most important things about bronchoscopy is a good knowledge of the airway anatomy. And unfortunately, there are several papers that look at airway anatomy. The dog, the cat, and the rabbit are almost all exactly the same. Dave Tweet has a paper on the cat anatomy, and Amos and McKiernan reported on the bronchial anatomy of the dog. And I think what is really helpful is to look at a radiograph and think about the anatomy and recall that the left cranial lobar bronchus is going to go in a hairpin turn cranially, similarly to the right cranial lobar bronchus. But then what I like to do is turn the radiograph upside down and think about the airway anatomy. And if we compare the bronchial tree to a radiograph, we see that as we come down the trachea we're going to make a right-hand turn and go into the left cranial lobar bronchus, come back to the carina, which is always a good landmark to use in bronchoscopy, go into the caudal portion of the left cranial lung lobe, and then we can go straight back into the left caudal lobe, and we'll see that airway bifurcations will branch at very regular intervals as we go off of these main bronchi. And actually, I have just noticed that I managed to flip this airway map. So as we look at this, this is correct. It comes down, go into the left cranial lobar bronchus, left middle, left caudal lobar bronchus. Then we're going to come down on the right side, and we go into the right cranial lobar bronchus, the right middle, the accessory, and then the right caudal. Now, how did I know that I had this image inverted? Because what I can see here is that the accessory lobar bronchus is in the wrong orientation. And if I flip this image, so bear with me while I rotate this image a couple times, and hopefully we'll get it into the right position. This is what happens when you try to do your testing right before you do the procedure. Oh, and I've still got it wrong, so I'm going to quit doing that and just tell you, I'm going to show you on this radiographic image. So we come down the trachea, we go into the left cranial lobar bronchus, the caudal portion of the left cranial, and then into the left caudal lobar bronchus. And then we go back to the carina for orientation, and I'll show you that on a video. Now, because I have totally messed up this discussion of airway anatomy, I'm going to give you another way to learn bronchial anatomy. This is a lung model that is made from a dog that had died, and we have taken off the heart and all the fascia, and we've rinsed the lung with water and then exposed the lung and the trachea to a constant insufflation of air over about 2 to 3 days. So we tie the trachea onto an air source, blow up the lungs, and now we have the perfect lung model for evaluating bronchoscopy and practicing bronchoscopy. Now, if you're in a clinical practice where you occasionally have dogs that have died from a disease process and the owners allow unrestricted use, that's another way that you can teach yourself airway anatomy. Now here's a normal bronchoscopy. We're going down the trachea to the carina, take a right-hand turn, and we've gone into the left caudal lung lobe. And you can see the airway bifurcations are very regular. They branch at normal intervals, always in a dorsal ventral and a left-right division. And there's a very sharp bifurcation between airway openings. So this is a normal individual where we see an absence of secretions, an absence of dilation, an absence of collapse. And we don't see any accumulation of secretions that might suggest a foreign body. So these are all the things that we're looking for when we perform bronchoscopy. Now, one of the important things that we're always assessing in animals with cough, especially small breed dogs, is the presence of airway collapse. These are images of tracheal collapse. Grade 1 is a 25% luminal reduction. Grade 2 is 50%. Grade 3 is 75%. And grade 4 is a 90 to 100% reduction in luminal diameter, or the W-shaped trachea, where the ventral portion of the trachea is actually bowing into the lumen of the trachea. And this is the type of tracheal collapse that Chick Weiss has referred to as a malformation. Now, one of the things that I wonder is whether a grade 1 can become a grade 3 over time. A lot of people talk about airway collapse as a progressive disease, and I'm not sure if tracheal collapse truly does that or not, but hopefully more studies will give us information on this. To me, tracheal collapse is not nearly as interesting as bronchial collapse, which we see in about 50% of the dogs that we scope. So here we are coming down to the carina in this dog, taking a right-hand turn into the left cranial lobar bronchus, and we see that that's 100% collapsed at rest. I use the same type of grading process for bronchial collapse as I do for tracheal collapse. So if there's a 50% reduction in luminal diameter, as we see in this left caudal lung lobe, that's how I would describe it. So left cranial lung lobe has 100% collapse, left caudal has 50% collapse. The other really common site for airway collapse is in the right middle lung lobe. So it's not just on the left side of the airways, it's commonly in the right middle lobe as well. And most dogs have multiple sites involved. Now, I used to think that bronchoscopy wasn't quite as interesting in cats as it is in dogs, but in fact, it is quite intriguing. We see a lot of hyperemia in the airways, a lot of mucus accumulations. We see some static airway collapse. This is the left cranial lobar bronchus in a cat, and we can see that it's collapsed at rest. We can also see that there's some narrowing of the airways in the bottom left and dilatation of the airways in the bottom right. So these are changes that are consistent with chronic inflammatory airway disease, chronic pneumonia, or even neoplasia. So they're not specific, but they are some interesting changes that I think will highlight the irreversibility of the disease process. And this is another irreversible disease. This is bronchiectasis with dilatation of the airways, first in a video on the left and a still image on the right. On the left, we see a lot of mucus accumulation, whereas it's not as obvious on the right. But in both images, we also see bronchitic nodules, so proliferative tissue on the epithelial surface that highlights the irreversible nature of this disease process. Now, this is a dog that one of our residents saw that had just a mild cough. It was so minimally affected. I said, why are we scoping this dog? And of course, I walk into the endoscopy suite when we're doing the procedure, and we see this, and I've got to be kidding me. This is a dog, believe it or not, that has Oslerus osleri, which is spread by regurgitative feeding by coyotes. Now, does this dog look like it's been fed by coyotes? Not really, but we made the diagnosis with bronchoscopy, which is another important reason for doing this procedure. So if we have some time for maybe some questions, Dave, and then we'll get to some of the procedures that we do with the bronchoscope.
Yeah, we've got a couple of good questions here. Is there any indication that you would prefer a rigid bronchoscope versus a flexible scope?
The only time that I use a rigid telescope to look in the airways is when I'm using a rigid scope for a laryngeal exam. And sometimes I have to do this because I'm showing something to the surgeons and I want to show it to them on the screen. And then I'll take the rigid scope down into the airways just to get a quick look. But the head and neck have to be very sharply extended so that you don't cause damage to the airway. So it's quite rare for me to use a rigid scope. And by the way, sometimes a laryngeal exam takes me longer than bronchoscopy. So I can spend 10 minutes doing laryngoscopy and then 10 minutes doing bronchoscopy. It should be a pretty quick procedure.
Yeah, you talked about sterilizing your scope with glutaraldehyde before storing it. Do you do anything prior to the procedure Um,
That's a really good question. We'll talk about that when we talk about BALs. But what I do is I do a full bronchoscopic examination. I look in every single airway opening that I can. And then before I do BAL, I pull the scope out of the airways, rinse the channel with sterile saline, and then I wipe down the outside of the scope so that it is as clean as possible.
so this is a question for the internist. I think I know the answer. Do you have surgeons perform the sedated airway exam concurrently with you at induction, or do you as the internist do it alone?
Well, I typically do it alone unless I want them to intervene. So if I have a brachycephalic animal and I want them to be taking off the palate and removing saccules, I'll have them there with me so we go straight from the endoscopy to the procedure. Or if I have a laryngeal paralysis suspect where I want to show them the image, I'll have them right there with me. Or if I have something strange, if I need them to do a biopsy of the larynx, or if I need their laparoscopic equipment, then I have them with me.
One last quick question. Have you biopsied bronchiectatic nodules?
I have, and I'll show you how we do that in the next section. Okay? Alrighty, so I'm going to talk to you a little bit about bronchoalveolar lavage and then the other procedures that we do frequently. One of the things that it took me a long time to convey to our anesthesia department is that we are not actually drowning the animal when we do BALs. Instead, we're taking a small endoscope to a very focal area in the lung, and we're flooding an alveolar segment with a certain amount of fluid. And depending on how big the animal is, how big the scope is, we use different volumes of fluid. So the yellow triangle is illustrating use of a very small scope, so maybe the 2.7 millimeter outer diameter in a cat, where we can use 3 to 5 mils of fluid to fill that entire alveolar segment. Whereas the red triangle is in a bigger dog with perhaps a 5 millimeter scope where we use 10, 15, or 20 mils of fluid. Now there has been a study published that looked at how much BAL fluid should be used, and to get a more predictable dilution of the epithelial lining fluid, they recommended using a weight-adjusted formula. So 7 mils for a 7-kilo dog will give you a more predictable dilution. I guess my viewpoint is that BAL dilutes the epithelial lining fluid by about 100-fold. So I tend to use about 1 mil per kilo, but then I round up or round down. So in general, for a cat and small dog, I'll use 3 to 5 mils. Medium-sized dogs about 10, and then a large dog about 20 mils per lavage site. And I'll inject and aspirate the fluid. If I don't get a good return, then I'll inject more fluid at that exact same site. And one of the other things that I'll throw out there is it has been reported that using suction pump aspiration is better than hand aspiration. I tried this when I was at the University of Munich and I didn't like it, so I use hand aspiration, and I teach all of our residents to do the aspiration procedure themselves. Don't always rely on the technician, because good communication between the endoscopist and the technician is critical in retrieving fluid. So we need to know what it feels like to obtain that BAL fluid. So this video shows a bronchoalveolar lavage where we're injecting about 5 mils of fluid. We're going to instill air to clear the scope. And during that injection of air, I say a little prayer to the BAL God, because that encourages return. And then I start aspirating the fluid. And if I have a little bit of dwell time, that will encourage the dusting up of the cells and retrieval of fluid. So repeat as needed if we get a poor return. And then I go to a second site. I clean the scope before I do my first lavage, but I don't clean in between lavages unless I've got a very purulent, heavy secretion of fluid. Now, normal BAL fluid looks like this top image on this slide. It's frothy, it's foamy, it's a little bit cloudy. Here is fluid from a dog that obviously has a very exudative process. Whether it's infectious or inflammatory, we're going to rely on cytology and culture to determine that. But this material can be so thick that it will plug the channel. So there are some times if I'm not getting a good aspiration of material, I have to pull the scope out and actually evacuate the channel. Other times I will primarily use more fluid to obtain fluid, the BAL fluid back. But sometimes you will have to actually evacuate the channel of this material. Other times when we get a poor return or with airway collapse or bronchiectasis, and if you have only a large GI scope to use and you're scoping a dog, you may not be able to get a good wedge with the scope, so you may elect to pass some of this polyethylene tubing through your biopsy channel deep into the lung to get a better wedge, because we have to actually plug a bronchial component in order to flood that alveolar segment. Otherwise, the fluid will just disappear from around the scope. So what happens when we don't get a good return? Well, maybe the scope is plugged, maybe we haven't got a good wedge. But I think the more common occurrence with me is that I have a dog that has bad airway collapse. And every time I suction through the BAL, I collapse the airway down on the scope. And so the two main tools that I will use to improve retrieval of fluid are to use more fluid and to try to gain more patience, because more fluid will add to the pool that I already have, and that'll encourage the fluid to come back to the scope. More patience, so using slow, steady suction, talking to my technician and asking them continually, are you negative? Are you negative? Which means, do you have negative pressure at the tip of my scope? And if that is the case, I'm constantly wiggling the tip of my endoscope so that the endoscope tip goes back and forth in the fluid, and I'm inserting and pulling back on the endoscope. So I'm going in and out of that fluid bolus so that I can get the fluid back. So I ask, are you negative? Are you negative? I'm going to use slow, steady hand suction, wiggle the tip, insert and withdraw the endoscope so that I get my fluid back. Now, sometimes I will do brush cytology. I would say that this is not really common situation, but if there's an endobronchial lesion, we may do brush cytology or we may do biopsy. One important thing when you're passing an instrument through the endoscope channel, make sure that you pull back into the trachea when you're getting the instrument near the tip of the scope, because these instruments can go straight through the airway. You can see in this video that the bronchoscopic brush is on a wire, and this will absolutely go through the airway if you're not careful. Now, I had hoped that bronchial cytology would be useful in those cases where I'm looking at a dog with airway collapse and the large airways look like they're very inflamed, but I get BAL back that is not very abnormal. In this particular study we did, it wasn't tremendously useful, so I don't do it very commonly, but certainly if you have one of those bronchitic nodules or an endobronchial lesion, it's a good technique to use. Now, this case illustrates the most common use of bronchoscopy in our practice. A large breed dog with a history of cough and recent weight loss. And when we go down to the airway, we see this little tiny yellow thing. And this is going to be a foxtail. So we have pulled the scope back into the trachea. We pass the biopsy instruments down to the end of the scope. And now we're going to approach this area and try to manipulate the forceps. These are standard biopsy forceps without a spike. Manipulate them onto the end of that foreign body. And one thing about airway foreign bodies, it's very commonly that it's the tip of the iceberg that you're seeing. Now, I'm showing this whole video because I can tell you that these can take a long time and they require patience. The lungs are moving, the endoscope is moving. Again, we're communicating with the endoscopy tech. We've got to be able to see the wings of that instrument before we can open up. And we're going to open and then try to close on that foreign body without closing on the airways, because you can see the airways are getting angry. And the more angry they get, the more they swell around that foreign body. And if the dog takes a deep breath, they can suck that foreign body straight down into the airway. So now you can see where patience plays a role. We grasp a hold of this. We think we've got it. Now we see the end of that foreign body, and we're going to slowly extract it into the endotracheal tube. And you start to see that this foreign body is a lot bigger than what it appeared to be. And we're going to pull back slowly until we have that in the endotracheal tube. We know that once it's in the tube, we can extubate the animal if we need to get it out. And then we're going to go back in and look for the next foreign body, because there are oftentimes multiple. This is where the anatomy plays a big role in our use of bronchoscopy, because we want to look in every single airway opening that we can. These are the instruments that can be used for foreign body removal. The wire snares are good for round instruments or round foreign bodies like small rocks. The balloons can put beyond a round foreign body. You can pop it out sometime. And in this panel, we can see that we have a very large foreign body where we've used the 3-prong grabbers. These are the scariest instruments that we use because they have a very long throw. They can definitely go through the airways. And the other thing they can go through is the scope. So we have to be very careful when using those instruments. I put up this slide just because we did a study where we looked at the ability of bronchoscopy to remove foreign bodies, and we've also published a paper in Vet Surg where we found that we could actually save lung lobes by doing bronchoscopy before surgery in animals. So we have a high success rate in retrieving foreign bodies, but the more interesting thing from this slide is that duration of signs had a mean and median, but very much longer than I would have expected. So some animals had foreign bodies in the lung for a year, and we pulled them out and their signs went away. Now, another technique that we use if we have an endobronchial lesion is endobronchial biopsy, and you could use this on a bronchitic nodule as well. What is challenging is to get this instrument on a bifurcation is easy, but to get it on something that's parallel to the scope is more challenging. The other thing that's challenging doing a biopsy is that the tissue is quite elastic, and we oftentimes have to use this biopsy instrument that has a spike on it, which then reduces the value of histopathology because you've got a 1.8 millimeter instrument and you've got a 1 millimeter spike in the middle of the biopsy. So it's pretty challenging. Now, one of the last techniques I'll show you is doing mass removal. This is from a cat. You can see that we have a large mass that is completely filling the airway. And we try doing biopsy with a standard biopsy forceps. And the goal is always to debulk an airway lesion. If you can imagine that this animal is going to be impossible to wake up from anesthesia because it has a huge mass in the airway. And you can see we were getting those really tiny pieces with the biopsy instrument. So then we took a wire snare through the endoscopic channel. And what I'm doing is trying to manipulate this around the mass lesion so that I can slice it off at the base and then extract the bulk of the mass. And this video shows that we were pretty successful in doing that. So we've extracted about 90% of the mass, we've suctioned the blood out, and so now the cat can wake up from anesthesia. The other technique that I use occasionally is a transbronchial aspirate. So I might do this in a dog that has hilar lymphadenopathy, as we see in the upper right-hand corner of this slide, or an animal that has an endobronchial lesion. So the long needle goes through the biopsy channel of the endoscope. The needle is retracted when the, we have to play with this instrument before we put it into the scope, so we know when the needle is within the guard versus when it's out. So make sure that you understand how to manipulate that. So we take the instrument down to the mass lesion we want to sample. Then we're going to extrude the needle, lock it in place, and then more or less jam it through the airway into a hilar node, or jam it through the mass lesion to get an aspirate. And I say jam because it does take a fair amount of force to do this. And I haven't had a lot of success with this. Obviously, you want to know the anatomy so that you don't mistakenly go into the aorta or the pulmonary artery. For some of you that work in multi-specialty practices, you may sometimes be called upon to do an endobronchial intubation. There's a number of different endobronchial blockers that can be used. And so I just go to the surgeon and I say, what do you want me to block? How do you want me to do it? Show me what you want to use. And then I'll use the bronchoscope either to carry the blocker down to the right spot, or to confirm that they've blocked the lung lobe that they need blocked. There are some complications of bronchoscopy. I would say that most of them are mild and involve desaturation. And if that occurs, if you simply pull the scope into the trachea, they usually will resaturate. If you are in a teaching institution and you want to teach students what crackles sound like post-bronchoscopy, you can oftentimes hear some crackles, and that can be a useful teaching tool. Usually the animals are hypoxemic when we start and they're hypoxemic when we finish. So I don't see that as a huge complication, but certainly worsened cough, worsened airway collapse are considerations. And then penetrating the airway is something we've already discussed. The top panel on this slide shows a huge mass lesion at the carina of the cat. The video underneath is post-debulking. And if you've ever wondered what the mediastinum looks like from a bronchoscopic view, that's pretty much it. And the cat was simply placed in oxygen, discharged the next day, and everything was fine. So that's what I had to talk to you about, the most fun procedure you will ever do in your life. And if anybody has any questions, I'm happy to answer them.
Yeah, Linnell, we have actually a number of questions, probably more than we have time to try to answer. But one of the questions, or there's several questions on your preference for BAL tubing versus using the biopsy channel, and which would you recommend?
I always use the endoscopy channel, but that's because I have a wide range of scopes that I can use in animals of different size. But I do recall when I didn't have all these scopes, I would pass polyethylene tubing that had been sterilized through the endoscope to get a more distal sample. If you don't have a channel on your scope, then I would say the ability to do lavage is pretty limited, although you could pass a catheter alongside your endoscope so you at least knew where the scope went.
Okay, good. There's a question on dosage for your BAL. Is 1 milligram per kilogram your maximum dose, or over at a single time, or an overall total dose? For example, if you have a 4 kilogram cat and use 2 mLs at a site and then 2 mLs at site B or whatever.
The fluid volume that I use for BAL is per lavage. And so I would inject 3 to 5 mils in a cat. If I didn't get any fluid back, then I'd stay in that same spot and inject the same volume. So I might use 10 mLs in that one site. And then I'd go to another site and I'd lavage again, always using about 3 to 5 mils per lavage.
In comparing BAL to brush cytology to bronchial biopsies where you can culture and do histopath, which do you think gives you the most diagnostic information?
I use BAL far more than I use brush or biopsy. In fact, every animal that we do bronchoscopy on gets a BAL. And I believe that the differential cell count and the total cell count are critical for determining the disease process. I know that there's some controversy about what is the value of a cell count, but I think that I look at BAL cytology like a CBC. So if I have a really high cell count, high neutrophil percentage versus eosinophil percentage, I'm going to use that to make my diagnosis. Endobronchial biopsies can be helpful. And if you want to biopsy a bronchitic nodule to prove that it's fibrosis and not a parasite, I think that's fine.
Do you always do a laryngeal exam before bronchoscopy, or do you sometimes do it following the bronchoscopy?
I always do it before bronchoscopy because there's always that chance that the animal might not be stable afterwards. If I am not sure of my laryngeal exam, I might repeat it after bronchoscopy, or if we have to intubate immediately, then I'll repeat it afterwards. But I feel more comfortable with what I see on induction.
Great. Well, I think that probably finishes up most of the questions. Thank you again for telling us about bronchoscopy, giving us all these tips and tricks for being successful. And thank the audience for joining our Endoscopy Talks webinar. This also can be seen recorded at a later date as well. Next week, we're going to be joined with Dr. Todd Tams, who will talk about the clinical utility of GI endoscopy in practice. And he probably is going to reveal some really great information on GI endoscopy. So I encourage you to join. That will be next Wednesday, July 15th at 8 p.m. Eastern Standard Time. Otherwise, wishing you all a good practice and good health, and we look forward to seeing you next week. So thanks a lot.